I am focusing much more on colon cancer and colon polyps than Dr. Meyer did, although she reminded me of some things I should mention, and so I'll try to address those too. Many people who come to our offices are really not happy to be there. They've been denying their symptoms for a long time, and typically it's all hemorrhoids. I find that what most people mean by "it's my hemorrhoids, doc" is it's my anus, it's bleeding, I'm constipated. You shouldn't be embarrassed. What you should be concerned about is that colon cancer is the third most common cancer in this country, and it's an equal opportunity offender. Men and women are affected at equal rates. It is the second most common cause of cancer death, and we actually have very high rates in Southwest Ohio for unclear reasons. So it turns out that actually the largest group of people with colorectal cancer have what we call sporadic cancers. This underscores the need for surveillance even if you have no family history. When should you be screened? Age 50, 10 years younger than the age your first-degree relative was diagnosed, and every 10 years thereafter, unless you have polyps. There are some genetic syndromes that make people more likely to get colon cancers. So if you have people in your family with histories of multiple breast cancers, uterine cancers, kidney cancers, all of these can be part of a colon cancer syndrome or a cancer syndrome that also includes colon cancers. Most colon cancers are adenocarcinomas. So even though the colon and rectum are a continuum, we talk about them separately. Colon and rectal cancers have very different behavior, and we have different treatment modalities for the two of them. We have great survival rates if we catch colorectal cancers early, and I can't emphasize that enough. Greater than 90% with stage 1 colon cancers. Stage 1 colon cancer being a T1 or a T2 lesion, so a cancer that's invading the mucosa or the submucosa that hasn't spread to lymph nodes. So initially we stage colon cancers with histories, some blood tests, CAT scans. The type of treatment is highly dependent on the stage. So again, with stage 1 cancers, we simply do a colectomy. Stage 2, it's questionable whether we give adjuvant chemotherapy. For stage 3 and stage 4 chemotherapy. Primarily, the distinctions are made between traditional open technique and laparoscopic technique. And these days, everybody wants a laparoscopic operation, and they can be great. There are definite advantages to doing things laparoscopically. But as you see, we make the small incisions, and we have long instruments that go through these trocars into the abdomen. This is post-op. This is from a right colectomy. Very important when we're dealing with rectal cancers to make sure we have an adequate margin below the cancer so that we know that we minimize our risks of recurrence. So I want to make the point again that it can be a preventable disease if you visit someone like Dr. Meyer and get your screening colonoscopy and have polyps removed before they turn into cancers, and that we can reduce mortality from colon cancers if they're caught early.